This is Enrique Bakemeyer with Healthcare Business Insights, and I'd like to welcome you to today's Thought Leadership webinar hosted with PMMC, Go to Narrow Networks, What's the Impact on Healthcare Providers? Slide 2, you will have the opportunity to ask questions during the webinar by typing them in the space provided in the open Q&A field on the right-hand side of the screen. We will take a couple of brief pauses to field questions on slides 13 and 15, and at the conclusion of today's webinar. If you have at any point during the webinar, please call our client engagement team at 888-700-5223 for personal attention. As today's program is being recorded, and registered attendees will receive a copy of the presentation slides by email in the next couple of days. Learning objectives for today's session: to describe the intended purpose of narrow networks as well as the unintended consequences, to explain the financial impact of narrow networks on healthcare providers, and the pros and cons of narrow networks. Turn it over to our speakers. Spend a few minutes reviewing some HBI research on the subject of today's webinar, and I'll launch today's first in-conference poll. Organization currently part of a narrow network? The answers are yes, no, currently in negotiation. Again, the question is your organization currently part of a narrow network? The answers are yes, no, or in negotiation. One reason we're excited to be hosting this webinar is that the topic of narrow networks is very much an area of emerging interest. While it's difficult to predict how narrow networks will evolve, they are one approach that stakeholders within the healthcare industry have come up with as a way to offer consumers coverage that balances affordability with quality. Those providers that do participate in narrow networks, one they may have to consider, this is something that our speakers will touch on during this webinar, one thing they have to consider is methods for tracking and reporting metrics related to cost and quality. And where HBI has another academy devoted to this very subject matter, the fittingly titled Cost and Quality Academy. And that academy has done some really great research on how organizations are doing benchmarking and data analysis of cost and quality metrics. One recent research study that we'd like to highlight here is on the work done by St. Luke's Health System of Boise, Idaho. The department at St. Luke's is organized with a central VP of Quality Operations who sees regulatory accreditations and all quality functions throughout the system, while site-specific quality administrators identify issues and facilitate improvement projects at the local level. Each administrator assists local unit directors and hospital staff in understanding quality metrics and maintains an everyday presence that helps keep staff focused on quality. On this slide is an example of how St. Luke's tracks and reports quality metrics at the local level. This is a quality dashboard used at the St. Luke's hospitals within the Treasure Valley region of western Idaho. This is used to track performance metrics such as infection rates, along with patient safety indicators and HCAHPS patient experience data. This board allows for straightforward comparisons to different facilities or different times of year for various data points. As you see, this dashboard employs the widely used red, yellow, green shading so that anyone viewing the dashboard can easily see where to focus attention and improvement efforts. This slide is an example of the St. Luke's Balanced Scorecard that is at the system level, which, like its local counterparts, includes metrics for quality, safety, and service. Organizations use a balanced scorecard to focus personnel on global expectations and maintain transparency. Then this St. Luke's scorecard shared with everyone from frontline staff to the board of directors. The card is interactive and allows for drill down at the site and patient level. Again, those organizations that participate in narrow networks, developing methods for analyzing cost and quality metrics will become a high priority, and our work with St. Luke's provides an example of how to do that. In fact, Luke's just presented a Cost and Quality Academy virtual conference called Structuring a Quality Department, a case study in offering local centralized support to facilitate improvement projects. If you have questions about the Austin Quality Academy generally, or specifically the playback for this St. Luke's virtual conference, reach out and we'd be happy to provide additional information. And I'd like to introduce our speakers for today's webinar. Gray, PMMC, and Gentleman, Esther of Chilman Law. Gentlemen, please take a moment to introduce yourselves. Right on.
Great. First, we'd like to thank HBI for hosting today's session. As we all know, the industry is transitioning from more of a traditional fee-for-service model to a much broader value-based, population health-oriented model. And in this transition, there are small steps that are occurring that are moving us through this process from fee-for-service to value-based. We appreciate the fact that HBI recognizes these changes, and we appreciate their leadership providing these educational programs for us to learn from each other and to share best practices. I'm Kay. I've worked with PMC in the managed care reimbursement area of the rev cycle for the past 20 years. And with me today is David Chilman, Chilman Law Firm, which specializes in assisting healthcare providers with negotiating and contracting with payers. David's a very unique perspective, having worked with Blue Cross Blue Shield for a number of years, and I go back probably 18 years. Dave, would you like to add more?
Yes, you, Greg. I appreciate it. In addition to my time with payers, I was also operations attorney for a large hospital system. I've been doing managed care and revenue cycle work for 25 years. And just like to say that some of you that have those wonderful contracts and enjoy that lovely language, I may have been responsible for that, so you're all very, very welcome. But I work with providers and help them unravel some of the mysteries of managed care and other care matters.
Great, thanks, David. What is narrow network? Well, it's a way for providers and payers to lower the cost of health care. In the healthcare industry today, as you all know, payers and providers are constantly negotiating terms to achieve the goal of lowering costs of health care, maintaining or improving the quality of care that we're offering to our communities. The concept of our network is where network members or patients to a specific group of connected healthcare providers where the insurance company has negotiated contributed rates for medical services. Behind this strategy of narrow networks, the provider agrees to accept lower rates in exchange for much greater volume of patients being referred to that specific network of hospitals or professionals, so they're receiving care specifically through that narrow network, hence the network. Although they seem fairly simple, there are various elements or components that can complicate things if sides don't know exactly what they're looking to achieve. So if you're contemplating entering into a network or contemplating not joining a narrow network, organizationally you need to first decide whether to join that network or not, and secondly, will it drive the financial results in a manner that you're expecting. Creating manageable risk is the key driving your line. So these names have been used or referenced for narrow networks. High performance networks is one example. The concept of managed care and managing cost sound familiar when we're talking about narrow networks. It really, because we've seen this before. Anyone that's been in healthcare for more than 10 years knows and has an appreciation for the fact that years ago, payers previously, quote unquote, missed the process under AMOs, POs, and managed care models. Many of the models still exist today, but on our network, payers are really continuing to tighten down the network, many ways similar to the PPO models of old, but to allowing the patient, if you will, to more self-select or self-direct to the that has the lowest cost, i.e. a part of that narrow network, and having the provider be more responsible for managing the care versus doing it remotely through the organization. The patient and the provider should be parties closest to the situation, and they should really know how to best coordinate the care for the best outcomes at overall cost to the system. So, with the resurgence, if you will, of neural networks, a lot of traction under the Affordable Care or Obamacare, many of the silver and gold plan or bronze plans being often narrow or ultra narrow networks. And this has led to very limited provider choices. So narrow networks being similar to some of the previous programs that have had limited success, and obviously, again, we're stair-stepping through this process over the years of trying to reduce costs and maintain and improve quality. So why are we seeing a resurgence of what we've been through in the past? Well, one reason is reducing the growing patient out-of-pocket cost is a real primary motivating factor. Patient deductibles continue to climb, and they continue to show a consistent climb or escalation in that real key area. For patients, if risk and quality are viewed the same, the patient out-of-pocket expense can be a tipping point for an individual to self-direct themselves to this cost or a narrow network provider. So for providers and payers, that cost savings and finding new ways to manage risk to improve bottom line comes into play so that all three parties are working together. I'm going to go, the Affordable Care Act, the ACA program, really began the process of this resurgence. But private employers, the response has been very slow. Many employers, due to various reasons that are cited here, have looked at other cost-saving options, but any of those options have played out. We look for new ways to lower costs, and as patient responsibility continues to climb, we've got other options to keep lower costs while maintaining the quality. One point in mind that while narrow networks lower, in many cases, the premiums, oftentimes it lowers the cost if the decides to receive the care in the narrow network provider. If it wants or needs to receive treatment from an out-of-network facility, those narrow network discounts wouldn't apply. There is some validity to really monitoring the narrow networks over multiple years to really monitor and maintain the success of cost savings, if you will. So patients are not only going to have to, again, the bar raised to self-direct into the low-cost option, but the providers are going to have to, again, be very focused in that registration process to identify upfront that paying in or out of the network. So while it has been slow in the terms of the last 3 or 4 years, there are obviously signs that anticipated savings appear to be appealing to some. As we hear, 38% of large employers now offer some type of high performance or provider network. We have another polling question at this point.
Yeah, Greg, and this time we will stop to do our second in-conference poll and also take some questions. As a reminder, please use the Q&A function at the top right-hand side to ask questions on today's topic. First, we'll share the results of our first in-conference poll. As a reminder, that question was, is your organization currently part of a narrow network? In the case, we had an even 50-50 split. We had 50% yes, 50% no, and no one answered that they were currently in negotiations. We will launch our second in-conference poll. The question is, does your organization have the necessary expertise to review contracts and payer policies regarding narrow networks? The answers are yes, no, or unsure. Again, that question is, does your organization have the necessary expertise to review contracts and payer policies regarding narrow networks? The answers are yes, no, or unsure. And I'd like to begin our Q&A with some pre-submitted questions we had. One thing about the narrow networks, this question is about the interest. Any view, or do you have any views on, have we seen anything in terms of the interest of narrow networks across the country? Is the interest uniform, or are patients in certain regions more likely to have narrow network health plans?
David, would you like to respond, or I can take?
I can tell you that on the ACA, networks are a vast majority of the offered products. In some markets, it's the only option you have on the ACA. That fully answers it. Greg, you want to expound on that at all?
Sure. Yeah, the ACA is definitely an area that has developed a foothold, if you will, with our networks. And obviously, communities or geographic areas where there are multiple health systems, and or in cases, large employers are looking to lower their costs, especially when they're self-insured. They're looking for providers to come up with ways to develop programs, and one option is being in the form of a narrow network to have, if you will, even tiered approaches to provide incentives for patients. So for organizations that, again, are a sole community provider network, you're probably going to see less pressure, if you will, from a payer contracting or employer cost reduction. So that's something you'll see across markets that will vary from area to area, geographic region to region.
Now here's another question. We talked earlier, a couple slides ago, about employers being cautious. What's the benefit to employers if they offer a narrow network plan?
Well, I can start. Oh, go ahead,
David.
I was going to say, obviously, if they're a self-funded employer, there are going to be cost savings associated with sending your employees towards these network providers who have met certain cost and quality standard benchmarks that I will talk about later. So there's these cost savings in that part, and it should also translate, if you're not self-funded, to premiums as a consequence of, again, lower negotiated rates for those providers. I can expand on that if you want, Greg.
No, completely agree with everything you just said.
That was a good sign. A question that came in from Joe. Are you seeing a trend toward providers in narrow networks providing a smaller scale of services, offering only total knee replacements, total hip replacements, and some cardiovascular services?
It's going to depend on the market and the organization. It comes to managing risk, and in some areas, those three examples that were cited are areas that providers have put a lot of effort into trying to develop out care paths and care path navigators to assist in both maintaining, not improving the quality outcomes, lowering the overall cost to the system, whether that be the payer, the employer, or the patient themselves.
All right, we'll take a couple more at this break. One, how do coverage renewals among patients with narrow networks compare to the renewal rate across other types of plans?
I've not seen those statistics, but I could certainly do some research, and we could send information out to the group at large following this session.
Got a question that came in here from Becky. Is there any significant impact in the case where individuals have both employer-provided narrow network plan and secondary insurance through a spouse commercial plan? How are metrics affected for monitoring total cost of care?
What's been your experience there?
No, something I don't have data on right now, but again, we could look into that and see.
Definitely respond to that question at a later time. Just a couple more here. How about for organizations located in areas with maybe only one or two significant sized employers, how can they make sure that they are included in their high performance narrow networks?
I want to clarify, did you say with only one or two employers?
For example, those, like we have the slide here that talk about the employers that have like over 5,000 employees. You know, for providers in an organization where maybe there's only one or two really significant employers with the health coverage, they can be sure that they're being, or what steps can they take to be included in those employers' narrow networks?
So from the provider perspective, you're saying, what can they do to be included in those networks?
Yeah, exactly. Like maybe another way to phrase it would be like, how can a provider make themselves attractive to a high-performance network?
Yeah, that's pretty straightforward. The two components, and one could argue whether it is deemed more important than another by whoever is footing the bill. But cost and quality benchmarks that are set forth to participate and to qualify in these networks, you know, they meet whatever benchmarks, and again, will vary by market, payer, employer group, if they're self-funded. You know, what are the benchmarks that are set for how you can be a part of this narrow network? Are you meeting certain cost and quality metrics, again, that I will discuss shortly. One way to ensure it. See what they are, know what they are, and then see if you can meet them. Because sometimes you may say, there's no way I can do this, or you might think, well, this is something I can stomach in terms of a discount, and I'll benefit from that through greater volume, patient flow, and market share.
And, you know, we'll take one more here before we turn the presentation back over to you. The question here is, if my organization is part of a narrow network, is it typical that we can see how we're performing on cost and quality metrics relative to other organizations in the network?
This is David. You know, I get into this issue again in the ensuing slides. How transparent is payer with respect to compliance with that? I mean, that really comes down to the flow of information that's come from the payer in terms of compliance metrics and whether the provider's meeting them, exceeding them. It really depends on the relationship, and it gets into some of the details that I talk about later on contractual terms and conditions on what can and can't be shared.
All right, good. All right, I will advance the slide once, and then I will turn control of the presentation back over to Greg.
We'll turn this over to David.
We'll turn it over to David.
So what I'd like to talk about now is, in addition to the HMO style of narrow networks, you know, with straight in or out of network PAR status, I just want to mention another type of narrow network, which is called tiered network. I want to touch on the quality and cost requirements for participation in narrow networks. Then I'm going to highlight some of the patient and provider perspectives on narrow network participation in terms of pros and cons. Starting with, you know, a tiered network. What is a tiered network? Rather than simply being excluded from a narrow network, providers are tiered based on quality and cost metrics. So if a provider meets the cost and quality metrics, they consider Tier 1, which means that a member would have a lower out-of-pocket cost. If they're Tier 2, it means that they didn't meet the cost and or quality benchmarks. So if a member goes to see that Tier 2 provider, it's still technically considered in-network. But the member's just going to have a higher out-of-pocket cost with that. And I say technically because there are some network adequacy issues that could be raised. There aren't enough Tier 1 providers in a given service area. It goes to some nuances with, what's being presented as enhanced benefits versus diminished benefits if you go to a Tier 1 or a Tier 2 provider. If you're a self-funded facility, you may offer an incentive to employees and dependents to receive services at your facility, which is really another type of mechanism. So on to the next slide, I want to talk about the metrics that I referenced earlier. To be part of a narrow network, you meet certain metrics. Typically, these are quality and cost criteria. And providers really need to understand, the criteria by which they're being judged, whether they're in or out of a narrow network. So let's talk about quality metrics. The first thing is, are these metrics objective? So are they based on objective data such as CMS data? Are they transparent? Can you review all of the metrics, verify them based on your own data, whether you meet these standards? It's really a matter of being able to see it for yourself and know whether you actually meet those standards. So again, you have objective quality standards. You may have transparent objective quality standards, but then are they fair to all providers? And this is where it often gets interesting, and I've seen situations where you have metrics that are objective and transparent, but maybe they're not fair to a certain provider because of case mix, for example. If a certain facility has a higher volume of very complex cases, it's really fair to compare and judge them to others that don't frequently see that level of complexity. So they may not hit that particular benchmark, but they're really seeing a totally different case mix. The other side of the coin is the cost criteria. Again, accuracy. Is the data even accurate? Obviously, the provider should be able to verify the accuracy of the payer's determination of their own costs of service. So you want to make sure you're on the same page. Are you saying that what I cost for a particular service is the actual cost? That's the first step. The second is, are they transparent? Again, back to this transparency issue. By transparency, I mean, can the provider actually verify whether they're higher or lower than another provider? Transparency tools in markets that should allow the provider to look at specific services and compare their advertised costs of service to other providers. However, we'll always include all services. It'll be a cross-section of services, for example, that are included in these transparency tools. So providers are truly often told, sorry, we can't tell you what we're paying to other providers, so you'll just have to trust us on that. And very much circular and very frustrating. And are these standards objective or discretionary? So you could have standards that are being portrayed as transparent or as being portrayed as objective. These are standards that we're judging you the exact same way across the board with respect to every provider that is in your area. Well, is there a discretionary component there that we don't really know about? That gets into what's in the details. The devil's in the details. Does the RFP or the contract or some terms and conditions say, yeah, there are going to be some discretionary components to this. You're not going to know what they are, but we're going to make the final determination. So it may actually be fair on the cost side. A perspective on our networks, and we already kind of went over this earlier, but just obviously you're going to have lower premiums. And I answered a question like this. What's the benefit? Well, lower premiums for the patient, it's the employer or the patient paying those. You're going to have lower potential out-of-pocket costs. What are the advantages? Your provider options. Have a long-standing relationship with a certain provider, and you're going to have to change that provider because that provider is no longer considered network for you. A much higher cost, you have to see an out-of-network provider Obviously, certain exceptions would apply based on network adequacy. For example, you should be able to see any provider, any member should be able to, at an in-network level for emergency care. From the provider's perspective on participating in narrow networks, advantages are cost providers benefit from an increased volume and increased market share. By offering that discount, see more members coming through your doors, so you'll benefit from that. And there's also the favorable public perception, often based on this representation of being higher quality and lower cost than others. What advantages? The level of discount that's required. How low or high is that discount that you have to give? Can you rate or even benefit from providing a discount, or would it destroy your budget if suddenly you had a much higher volume of members coming through with that particular plan? It depends on the situation. Member volume can change on it. So remember, this can happen often at the sole discretion of the payer. Maybe give a significant discount, but think, well, there's a low number of members in here in this product, so I'm willing to give it a try because I want to have that perception of being an efficient and high quality provider, and it won't have a huge impact on us. Or maybe comfortable with the discount that was offered or negotiated, and you're counting on this huge volume of members to justify the discount. Again, it can change, so you need to understand what those expectations are. And benefit plan restrictions. Narrow network have certain policies and benefit plan terms that are more restrictive than other products might have. For example, billing guidelines or coverage exclusions that are not reflected in the actual rates. So oftentimes just focus on the rates, and there might, but how do you know that it's really apples to apples in terms of the revenue stream? Any additional contract terms tied to this? There could be onerous terms that you have to agree to related to this. What is the impact discount, if you have it, on negotiations and products? Well, look, if you can agree to this discount for this product, well, same discounts they gave us for this for all products across the board. We expect this now. You were able to do it before. You're still standing. You're still alive. Now we want this on everything. What's the duration of participation? It's related to the concept that I just mentioned in that, how long are you deemed to be in this narrow network, either whether it's a Tier 1 provider or part of that narrow network. For example, if it's for 1 year, you get a wonderful note or an RFP at the end of the year saying, thanks for your participation last year, but if you continue to be in this narrow network or Tier 1 provider, you give us an additional X% discount. Eventually it can become a race to the bottom in that regard. In some cases, it could be worse because of public perception issues and member transition issues. Oh, wait, you're no longer a low-cost and a high-quality provider? What happened to you? Obviously something terrible. Bottom line is that if you want to be able to rely on your expectation as being represented to you while minimizing nasty surprises, and I'm going to talk about this more, you have to understand and negotiate appropriate contract terms and know those terms and conditions, and it's important to do so. Moving to the next slide, what is the provider's perspective on non-participation in narrow networks? So obviously the advantages are going to be you're not giving an additional discount. You don't have that. You're not going to be subject to restrictive policies that are part of that particular product. There's not going to be a negative impact of this discount on future negotiations or products, the expectation of, well, now you got to give us the same thing, and so on and so forth. The disadvantages, out-of-network, lower-tier designation can create collect challenges. You have a much higher member responsibility, so that's going to impact you. You're going to have potentially public perception issues. The perception is being created, I believe, that you're not cost-efficient and a high-quality provider if you're not one of them. You've got lower patient volume, ostensibly because folks are going to be channeled to the network providers. And, this payment directly made to members issue is related to collection AR challenges. And in some states, certain providers, or I say payers, are able to ignore the AOB and send it directly to the member. So this results in a really perverse scenario where members can really play the system, use the whole thing as sort of their own personal ATM, make visits to the ER, and I've seen this, wiping all of the checks that are sent directly to them by the payer. It's the opposite of what these narrow networks are supposed to do, which is to incentivize appropriate use, cost-effective use of healthcare services. It's actually the opposite. And like I said, I've seen this. There are ways to combat it, but I've seen it literally add millions of AR to providers that are caught in that situation.
David, am I taking the question break now, or do you have more on this slide?
No, that's it for that one.
Okay. All right, yeah, well, at this point, then, we will pause for our second scheduled Q&A break, and we'll do our final in-conference poll, but first we'll share the results of our last in-conference poll. As a reminder, that question was, does your organization have the necessary expertise to review contracts and payer policies regarding narrow networks? The results are yes, 68%, no, 14%, and unsure, 18%. Now, we'll launch our final in-conference poll. Does your organization have contract modeling technology to understand the financial impact of being a narrow network? Answers are yes, no, and yes, but not confident in it. That question is, does your organization have contract modeling technology to understand the financial impact of joining a narrow network? The answers are yes, no, and yes, but not confident in it. And with that, I'll turn one more questions to David and Greg. So at the bat, here's a straightforward one. What are some common quality metrics providers are judged on?
A couple would be, readmission rates within 30 days, infection rates, when they're in the facility. Those would be two examples. Greg, I don't know if you want to add some additional ones.
Those are top two that we see, David.
Cool. Do you anticipate that providers participating in MACRA might become targeted for narrow network participation because they'll already be reporting quality data?
Targeted. Go ahead, Greg. Go ahead.
I was just going to say, if the question is tied to will MACRA data be used, we believe it will. Similar to ACA, drive sort of a renewed interest in narrow networks. I think from a professional side, we'll just continue to push in that direction.
All right, here's another one. Here, our organization has multiple hospitals and numerous outpatient care sites. Are we large to be included in a narrow network? Is there an ideal size or type of provider to be included in a narrow network?
I don't think you can be too large in a narrow network. There are instances in markets where you have very large facilities. One is a network, and the other large facility is not in the narrow network. And I don't think that plays into whether you're in it or not. I think what can is, providers there are around you would make the narrow network an effective concept, because the network concept's really only effective if there are providers that are not in it, that your hope as the provider in the narrow network, you're hoping to gain market share and gain pay from that other provider, if that makes sense.
Yeah, much. We'll take a couple more questions at this break, and as a reminder, folks, please feel free to use the Q&A feature to add some questions into the queue. Has anyone studied whether care utilization differs among patients who have network plans compared to patients with broader plans?
Has, and a few others, McKinsey has done studies on that, and similar to a prior question, we could certainly pull together some research and with the participants on the call today, but off the top of my head.
And another one, do neural networks typically have a higher proportion of non-covered services to your knowledge?
It depends. I mean, there are cases where there could be, depending on the market and the payer that's offering those services in that market, they might say, well, these, for this network, we're offering this benefit plan. It's really benefit plan terms and conditions. Yeah, this may not be a covered service. So it varies, and it can be that way.
We'll wrap that Q&A session there, and I will turn control over to David or Greg. Are you taking control for this home stretch of the presentation?
I'll take this one, and I think, at this point, Greg and I are going to talk about identifying a narrow network, including the importance of contract language and terms and conditions, risks that I mentioned earlier, and of course, population health. So you'll hear from both of us in these doing slides. Really, one of the concepts is that's important in identifying a narrow network is knowing your payers and their product names. So know essentially that coming through your doors and you're processing them correctly. So there should be constant communication between the managed care department, patient access staff, so that patients are being registered correctly. But remember, not all product names are on guard, or product names are constantly changing. So understanding the various products that are being offered by payers area, and the networks through which they're being offered, so that you identify them and catch them as they're coming through. So I think this slide says it all. I mean, it's extremely important to fully understand your payer contract language and the potential financial impact on your system, facility, or your practice. Two are very much related. The terms of condition, the terms of participation in these networks, carefully reviewed, and it includes any language contained in the reimbursement exhibits. Now, I could do an entire presentation on gotchas on language in general. Right, we're just focusing on those related to the narrow network concept. But what are terms, for example, that allow the payers to even create the narrow networks? There could be language that allows them to summarily create a narrow network on terms of your current arrangement, and anticipate that. So, anywhere buried in that language, or in the or possibly even in the policies and procedures, there could be the ability for them to do that. That allow payers to unilaterally a provider as par or non-par in a narrow network product. Because sometimes providers want to be in the product. They want to be in it, but they're prohibited. They're told, you're not in it, we're not even going to give you the opportunity. Other times they want it, but suddenly they find that they're being forced to participate in a narrow network product under the existing contract that they have. So it creates a very sticky situation where they can't extricate themselves without terminating all lines of business, which isn't always feasible. And even terms of which I have been made and seen that allow for separate and unknown rate schedules for various product lines, including narrow networks. So you're going to participate in a narrow network under some unnamed fee schedule, and then you get, sort of a nasty surprise that, well, these are the terms under which you're going to be compensated this arrangement. So providers do their homework. The problem is it's not always identified in the contract. It's not clear. In fact, as I said earlier, when doing this, it is ambiguous language, often designed in the contract that to the untrained eye wouldn't even appear like it means anything, but it speaks volumes as to what the payer and payer cannot do. Perhaps language isn't even referenced in the contract at all. Not stated. Most payers require adherence to policies and procedures as modified typically, usually. Are often able to control that relationship through those policies. So it underscores the importance of actually being able to specifically identify terms in the agreement, if possible, that really put parameters around your expectations. Really the narrow networks, again, this applies to everything, but the narrow networks, your participation in them, your participation in them, rates, and then it may be in the reimbursement exhibits, or it may be through a separate RFP that's presented to you, which will be essentially another type of contract that you have to review. Related to that. That's for that slide. So, Greg, I'll hand it over to you.
Thanks. So as David noted, providers do their homework not only with the reimbursement language itself, but it has to be a real clear focus around the reimbursement provisions. And your homework should include the financial modeling of all actual plans and product lines. And we believe that the best way to analyze the data is in a true side-by-side fashion, where you're looking at each plan, each product line, and then doing scenarios of your current reimbursement to proposed reimbursement for this contract that you're looking at. The thing with looking at other reimbursement benchmarks, a lot of organizations will use Medicare as a baseline to what is being proposed to Medicare, looking at proposal number 2, proposal number 3, proposal number 4, again, in a side-by-side consistent way. Data reimbursement levels really being squeezed tighter and tighter. Every provider, especially acute care providers, should have a true contract management modeling tool that states the expected reimbursement using your account history. And often this means moving beyond Excel, which is often used by hospitals and large care systems today, but really moving beyond Excel to calculate all of the details and all the layers of contractual terms and reimbursement rate schedules. So you do calculate out, as the example shows, this is just an example, all the different code billing combinations to what the adjusted expected reimbursement is going to be for each individual payer plan area. Type of side-by-side analysis is critically important to really understand where financial winning and losing will occur, because obviously to have a true win-win contractual arrangement with the payer, you have to model everything out. David noted you have to understand all the reimbursement language provisions, but you also have to model the true reimbursement rate systems to understand what you're getting into on the front end. So go ahead.
Sorry, you were going to talk about the next slide. Sorry, go ahead.
Yep. So just keeping the financial benefits to providers are obviously not a guarantee. Same thing with narrow networks. On the success of key factors like membership volume, David touched on, plan restrictions. This could be specific to certain procedures. Obviously, ultimate impact of the discount, what you're willing to accept for reimbursement services will have impact. But the overall forces and processes with narrow networks do begin to align with future population health strategies. There was no question earlier related to things like CJR, knees and hips, CAC services that CMS has been promoting recently over the last couple of years. So this is a tie for narrow networks and for population health strategies. And to succeed in both, you have a couple of critical pieces, which start with solid data analytics, really the reimbursement for your services, in terms of the reimbursement language, what you're willing to accept, and the fee component of how you anticipate or would receive as reimbursement for those services, and then to align your community of patients so that they're self-directing to the right place. And provided a couple of examples of that doesn't always work through the R and the patient ATMs that he used as the example, but to align that community of patients with your care coordination program. Obviously, by doing the proper research so that you're in on what you'd like to accomplish with a narrow network, really helps you better prepare to negotiate the terms that will have the biggest impact on your organization's bottom line. Negotiations are all about managing risk, and hopefully this session today offered some insight into negotiating reimbursement provisions. And in September, we'll be doing a deeper dive with HI into payer contract negotiation strategies. So I hope everyone that's participating today will join us in that next session coming up in September. But as it relates specifically to this session, David, would you have any additional thoughts?
Thank you, Greg. I think you touched on it well. Again, just emphasizing that providers need to really do their homework. It includes analysis and understanding of the terms and conditions and modeling. Obviously, though, you have to have a solid foundation and understanding of the terms and conditions before modeling. Obviously, modeling isn't helpful if you don't fully understand the implications of what you're agreeing to, or if there can simply change the terms at will. And I like to say it's like trying to build a solid structure on shifting sands. It won't work. So that's the emphasis on doing your homework in that regard.
Well, at this time, we will thank Greg and David, and we will do our final Q&A session. Once again, please use the Q&A feature at in the top right to answer questions. Before we get to that, the final in-conference poll result. A reminder, that question was, does your organization have contract modeling technology to understand the financial impact of joining a narrow network? The results there were yes, 70%, no, 13%, and yes, but not confident, 17%. And now some final questions to end the session. What are some examples of an ambiguous contract language or terms that might indicate a provider is in a narrow network without their knowledge?
Okay, like I said, I could do an entire session, multiple ones on the ins and outs. So many variations. I see so many different payer contracts, and even within payer contracts, there are different variations of them. However, without obviously getting into explicit language that might be, common language, something like that says that you're going to participate in these types of products. Say, any network or anything, that allows us to determine participation or non-participation. It'll be really ambiguous in terms of, it won't say necessarily narrow network. It'll say something like they have discretion and you're part of anything essentially that they say you're a part of. I've seen explicit references, and you have to pay attention to it. I've seen no explicit references, but language that gives them the discretion to make that determination. You're going to participate in the various products that we offer. Well, the time in which you're entering into the agreement, that doesn't exist. But when you're contracted with them, it suddenly exists, and now you've agreed to participate in that product. So what you're entering into at the time isn't always the same situation a year, 2, 3 years later when you're on old paper, and suddenly now you are in that unknown product. You had no idea about it. You had no idea what the implications were, and you're in it. And then, of course, there could be other language that relates to how you're going to get compensated for that which you may not like.
Another question that came in now from Rosalind. How are narrow networks today similar to silent PPOs of the past?
It just depends on the situation. It's not silent PPO if you are agreeing to participate in a network. If it's something that you want to do, interested in it, you're comfortable with the terms, and you agree to participate, subject to the issues that I discussed earlier. I think you might feel like you're being taken advantage of, or you have somewhat of a, quote, silent PPO. And I say silent PPO in quotes because there's a legal component to what actually constitutes a silent PPO. But essentially, if you have no intention of being a part of it, or perhaps, let's say, some other payer or TPA has now latched on to the fact that you've agreed to it, there'd be a component of that there. It depends. If you say, well, I didn't intend for this third to access this narrow network at these rates, you might have a problem there. And again, it goes back to what on the front end are you doing to ensure that doesn't happen. And not always happen, but it is a possibility.
Thank you very much. Got another question here from Becky. Are you aware of any organizations with sustainable models for delivery of primary care that operate in a narrow network? How sustainably are prevention services and well-managed chronic illnesses reimbursed within a narrow network plan?
Not aware specific item. Dave, you have any?
No, I don't have any specific data on that, on those specific questions regarding the reimbursement for that.
Fair enough. We'll put the file that under never hurts to ask.
Yeah.
A couple more then here, and if anyone has any other questions, please do get them in the queue. Here's another one that we'll see, another one that doesn't hurt to ask. How do reimbursement rates in narrow networks compare to average rates in broader plans?
Well, it's fair to say that they're going to be lower. The point is putting up something to the member, so you expect to pay a lower premium. You're going to have the choice that you have. And in order to do that, the payer is going to say, well, provider, you're getting something, ostensibly, which is the name of patients that won't be going to the non-narrow network provider, so you're going to give us a better deal on it. The question is, what kind of a deal? How much discount? I mean, low single digits, it could be, easily well into the double digits.
All right. We'll wrap up now with one final question. Are there any terms providers can insert into contracts to ensure a payer can't put a provider in a narrow network without discussing it with the provider first?
Yeah, that gets into specific language that I'm happy to take questions offline and discuss that. But there are numerous things you can do to find and articulate what it is you want to participate in or don't participate in. But I hate to give specific legal language right now over the phone relating to that.
Fair enough. Well, I think that brings us to the end here, so I'd like to again thank you, Greg and David, and all of our attendees today for the Thought Leadership webinar hosted by PMMC, Intro to Narrow Networks, What's the Impact on Healthcare Providers? We need you now to mark your calendars and attend the third PMMC webinar in this series, which will take place on Thursday, September 14th, and will be on the subject of the contract negotiation process, and is slated to feature Susan Mago, the Executive Director of Managed Care for the Metro Health System. Again, it's Thursday, September 14th, on contract negotiation process. Until then, thanks again. Have a great afternoon and a great rest of the week.